So screening examination of the brachial plexus for clinic. First thing to do is look at the patient's face. The reason we're doing that is you're trying to determine, is there a Horner's sign? So is there a partial ptosis, a meiosis or constriction of the pupil, and is there dry skin on the same side of the face? The reason we're doing that is that could imply there's a very proximal injury to the lower plexus, such as the T1 root, which could be avulsed. Next part is to actually look at the shoulder blade position at the back. If the patient can bring the two shoulder blades together, so bring the shoulders together, and you can feel the rhomboids and levator scapulae, then the dorsal scapular nerve is working, which is the most proximal branch of C5. And that again tells you that it's unlikely then that there's an avulsion if that's working. Next thing to do is examine the brachial plexus systematically. So we start from C5. C5, the first branch from C5 is the suprascapular nerve. To examine that, tilt the head towards me, that relaxes the trapezius muscle, and lift the arm up into the air with the thumb internally rotated, supraspinatus contracting, and then with the arm adducted, ask the patient to swing out against pressure, always feeling the muscle, so there's good contraction within the infraspinatus. So suprascapular nerve is fine. Continuing the journey along that upper trunk, C5 has a posterior division. Posterior division of the upper trunk is the C5 contribution to deltoid, so push up to the ceiling. Anterior, middle and posterior all working. If you want to check the posterior, which is important when you're looking at regeneration because that recovers first, is push backwards here, retropulsion. And then in this position, swinging the arm to the ceiling is feeling for teres minor, which is contracting. So that's all C5 innervation. Next thing, coming up back to the upper trunk, C5-6. The C6 contribution is elbow flexion. So bend the elbow up to the ceiling. Biceps is there. You can also feel the biceps tendon. Bend again. In pronation, I can now feel the brachialis contracting. And in mid-rotation, bend again, you can see brachioradialis. They're all innervated through C6. There's some C5 as well. The C6 contribution into the upper trunk obviously gives the anterior division of the upper trunk, which is going to become the musculocutaneous nerve and the lateral head of the median nerve. And then there's a posterior division we'll go back and examine in a minute. So we've already done the musculocutaneous nerve. We'll go back and do the lateral head of the median nerve. Lateral head of the median nerve is C5, C6 with a bit of C7. So whilst it's mainly sensation in the hand, what we want to determine is the motor innervation through the lateral head. First one is pronation. So turn the hand to the floor. Don't let me twist it back, and I can feel the pronator teres contracting. Relax, do that again. You can see the pronator teres here, inserting to the midpoint of the radius. If you put the arm straight, that's supposed to isolate the pronator quadratus, but you can't separate out the two functions. Pronator quadratus is C7 and C8. So PT, C6, 7 coming through the lateral head of the median nerve. There's also a little bit of FDS, bend up. FDS also has some C7 contribution, as does FPL. They're all working. FCR, bend the wrist to the ceiling. You can see FCR contracting here. That's all lateral head of the median nerve. We'll come on to sensation in a minute. Going back to the upper plexus, the lower plexus C8-T1, we've looked for a Horner's sign. Next branch is the medial pectoral nerve, which pierces pec minor, comes onto the lower pec major. That's working. Push your arm into your side. You can see the lower pec and feel the contraction in the anterior axillary fold. The next motor branch is actually the humeral head and then the ulnar head of the FCU. So bend the wrist to the ceiling and you can palpate and feel the FCU. Next motor branch is the FDP, to the ulnar side of the hand. You're checking small finger resisted lift off. That's contracting normally. So that tells me that the innervation of C8 through the medial head of the median nerve is fine. Medial head of the ulnar nerve, medial cord is fine. Spread your fingers apart. Now I'm testing the ulnar innervated intrinsics, which is T1. And turn your hand over, lift the thumb to the ceiling, and the median innervated intrinsics. So from C8-T1, C8 is predominant finger bend and also some finger extension we'll do in a minute. T1 contribution is the sympathetic outflow to the face, but then it comes all the way down, medial head of median nerve for thenar muscles, and ulnar nerve for the rest of the ulnar innervated intrinsics within the hand. We'll go back and do the posterior cord. Posterior cord is formed by branches from the posterior divisions of C5 through to T1. We've already done the C5 contribution to the shoulder, so the other posterior cord origins are 6, 7, 8 and T1, and in turn C5, 6 is in the shoulder, so we can keep the wrist straight. What I want you to do is to pull in against your tummy. With the wrist straight, he's internally rotating rather than recruiting his pec, that's subscapularis. Push your elbow into the side, I can feel the teres major, and also push into the side. I can feel that dorsi, which is the next branch, comes off the same axis as the lower subscapular nerve in some patients. Next thing is push the arm out straight, long head of triceps, then the lateral head and the medial head of triceps are all functional. We don't bother with anconius, which comes off the medial triceps branch. We then look at ECRL, lift the wrist backwards. ECRL, ECRB, we've done brachioradialis, ECRL and ECRB are wrist extensors, as is ECU. So in order, ECRL, ECRB, supinator, then we've got EDC, ECU, and then finally we come down onto the thumb extensors and the index EIP, which is the terminal branch down here. So when we're doing the posterior cord examination, we tend to go in sequence. So BR would be our first after triceps, ECRL, ECRB. So when it's re-innervating, you'll find that the wrist radially deviates rather than central, and that's because ECRL kicks in and gets stronger before ECRB. So here, wrist backwards, absolutely fine. EDC, the best way of examining is to make a fist, assuming the medial cord and median nerve are working, and then straighten your knuckles, and that's EDC function isolation. Relax. Otherwise, patients who've got a radial palsy will be able to open their fingers but won't be able to straighten their MCPs, and they can open their fingers using the intrinsics like this. So you need to lift the fingers up to examine the intrinsics, and if the patient's got paralysis of the radial nerve, you can do it in this position to examine the intrinsics. But the true test of EDC is with fingers bent, lifting the knuckles. With the thumb, you want to look for retropulsion of the first ray, that's EPL, and then, of course, the final one to re-innervate, EIP. Other motor assessment, trapezius, so it's really good for as a donor, an extracaxal donor for reconstruction of the plexus. Phrenic nerve, which you test with fluoroscopy, and intercostals look for rib fractures. Sensory assessment, so now we're talking about the dermatomal innervation. C5 is the outer arm down to the lateral elbow, C6 front and back forearm, C7, C8, T1, and then T2, which is the lateral intercostal brachial. But of course you've got to remember, not everyone looks like a brachial plexus injury with a root, so sometimes it may be a cord level problem. So if you've got a lateral cord problem, the lateral cord would take out the lateral head of the median nerve, and remember that the median nerve supplies this part of the hand, C6 and C7, so that's all the innervation from the lateral cord, but also the muscular cutaneous nerve, lateral cutaneous nerve of forearm. So a lateral cord sensory loss will be lateral cutaneous nerve of forearm and median nerve, including the thenar. The C6 root problem would be front and back, encroaching on the radial nerve territory. And that's how we distinguish the two. The posterior cord, isolated axillary nerve, if the posterior cutaneous nerve of the arm, posterior cutaneous nerve of the forearm and radial nerve are all involved, and that's a posterior cord lesion. And a medial cord injury is the ulnar nerve and the dorsal branch of the ulnar nerve plus the medial cutaneous nerve of forearm and medial cutaneous nerve of arm. So the sensory loss is more than you'd expect with an ulnar nerve in isolation. So that's it, that's the conclusion. Always in the exam, feel for pulses, and really at the beginning you should make sure there's a full passive mobilisation, and as with any examination you look for asymmetry and comment on scars and wasting.